I'm Sam Schulman, and I'm working with the blood thinners at McMaster University in Hamilton, and both the old ones and the new. So the main old one is warfarin or Coumadin, and I've been working with that for 30 years, trying to improve life for patients, trying to find better ways to use warfarin. So, for example, one study that we published a few years ago was for patients who are very stable, can they have a decreased burden of the monitoring, because with warfarin you have to go for blood tests all the time. And we found in that study, which was published in Annals of Internal Medicine, that patients could actually wait up to 12 weeks instead of 4 weeks. So that's just one example of making life easier. Now I'm also working a lot with the new blood thinners, and that's the study that was published right now in Circulation on how to manage patients when they go for surgery. Because when these new drugs are approved, they have had large trials that show essentially that they are effective and that they are safe. But those large trials do not answer all the practical questions that come up afterwards. What do you do in case a patient is bleeding, which we will hear soon about? And what do you do when you need to take the patient for surgery, which you will also hear from my colleague here. So, but he will talk about warfarin. And my study was on one of the new blood thinners, Dabigatran, but it is applicable to the other two agents as well. The problem with these new agents when they come out and these questions are not resolved is that physicians do whatever they think is best. And that can be harmful for patients. Some of them will stop the blood thinner too early because they're afraid that the patient is going to bleed during surgery, and instead the patient can have a stroke while they're waiting for surgery. Some of them stop the drug too late and the patient can have a bleeding. And the same with restarting the blood thinner after surgery. How soon can we do that? And then there is another question that applies both to Tom Ortell's study and my study is, do you need, while the patient is off the blood thinner taken by mouth, to give something by injection? And I and my colleagues felt that specifically for the new blood thinners that stop working quite quickly and start working essentially immediately, that there is no need to give heparin injections. But you see out in the clinics that physicians do that anyhow, and that could be harmful. That could increase the risk of bleeding when you give additional blood thinners. So it is important to test the best possible strategy for patients on the new blood thinners, and that's what we did with Dabigatran, which we chose because that was the first one out, and we had enough patients out in the community on this drug, and we could, with the help of Heart and Stroke Foundation funding this study, evaluate that in 541 patients here in Canada. And our strategy was to stop the drug as late as possible, but different for different patients depending on how big is the bleeding risk of the surgery. So it's different if you go for an endoscopy where you just put down a tube and maybe take a biopsy, or if you go for brain surgery, obviously. So you double the time if you have high-risk surgery between stopping and the drug and starting surgery. But you also have to take into account for these new drugs to smaller or bigger extent the kidney function, because these new drugs are more or less eliminated from the body by the kidneys. And if the kidney function is worse, they stay longer in the body. So we have to increase the time, and more so for Dabigatran because it is really dependent on the kidneys. So we had between 24 and 96 hours of interruption between the last dose and surgery. And then restarting is only based on when the patient has stopped bleeding and the bleeding risk of the surgery. So in some patients, we started the same evening. If they had an endoscopy, for instance, we could start back the same evening. Otherwise, 1, 2, or 3 days, depending on the... So brain surgery, we waited 2 days. And with these 541 patients, we had no strokes. So this is the worry. These are patients with atrial fibrillation, irregular heartbeat. They are on the blood thinner because you want to prevent stroke, and that's what you don't want to happen after surgery. So we didn't have a single one. We had one patient with a, you call it mini stroke or TIA. It's brief neurological deficit that disappears without any residual effects. It can last for a few minutes. So that happened in one patient. So that's a very low event rate, extremely low event rate in 541 patients. We had 10 major bleeds, but most of these bleeds, they were related to the type of surgery. So very large surgery. One of those was, for instance, a huge tumor that took 5 hours to operate on. One was an open heart surgery, and some were hip replacements where it was a second time. So when you go in a second time and replace hip prosthesis, it's more complicated because the tissues are scarred and it bleeds more. So it was not really attributable to the Dabigatran, and therefore with 1.8% risk of major bleeding during the 30-day follow-up, it's comparable to other studies. It's a low risk, it's completely acceptable, and it's very hard to get lower than that because when you cut into somebody, they have to bleed, and if it's a complicated surgery, there is an increased risk of major bleeding. So by having this and without using heparin, without giving injections with heparin in the meantime, and this is very important because, as I said to you, some of my colleagues think you have to do it, and that has by another one of our colleagues been shown actually that it can be detrimental in patients on Dabigatran to do it. So we didn't do it, and so even without that we had this extremely low stroke risk. So really there is nothing to gain by injecting the patient with heparin, and we need to spread this out. That's why we're happy that it was published in a high impact journal and circulation. We're happy that maybe some of you can spread it out. Patients should not get injections with heparin unless they cannot take the tablets after surgery. If they have had bowel surgery and the bowel is not working, they cannot take by mouth. That is an excuse. Then you have to give injections with a blood thinner until the patient can start taking again. So I think that summarizes the study.